Good afternoon and welcome to this month's Health Policy Grand Rounds from the Institute for Health Policy Studies at UCSF. I am very pleased to introduce Naomi Bardock, who is our speaker this month. Dr. Bardock is a professor of pediatrics and health policy in the Department of Pediatrics and at the Philip R. Lee Institute for Health Policy Studies at UC San Francisco. Her research program focuses on improving the quality of inpatient and outpatient pediatric care. She's a pediatrician at Zuckerberg San Francisco General Hospital. Starting in April 2020, she focused on school reopening during the COVID-19 pandemic for California, leading research on school testing and becoming a national and international expert on an evidence-based public health approach to schools during the pandemic. From December 2020 through September 2021, she served full-time at the California Health and Human Services Agency as the state lead for the multi-agency Safe Schools for All team. I am really excited to learn from Naomi about her experiences in this role, as well as how it fits into her broader body of work in health services research and advancing pediatric care. So Naomi, I'm excited to introduce you and hand it off to you to begin the grand rounds.
Wonderful. Thank you so much, Joanne. It's really wonderful to be able to come and speak and share with this group actually all the lessons learned and the very interesting experience. So I'm going to try and share my screen in a second.
Right. Well, you're doing that. I will note to the audience that we have a question and answer box. And so if you have questions, there will be time for Q&A. Please type your questions into the Q&A at the bottom of your screen. And when we get towards the end of our time period, we will make sure we have time to go through at least some of those questions. And so that if you have thoughts and queries for Dr. Bardock, type them on in. Thank you.
Thanks so much, Jan. So I have nothing to disclose, but I do want to acknowledge that all of the work that we do in COVID in schools is like an extraordinary team effort across multiple sectors, lots of collaboration. I'll speak more about that actually in the middle of the talk, but it's a really important piece to say that we are in it together, and that's how we're going to continue to get through this pandemic. So an overview of the talk is there's three sort of themes that come out. One, particularly for the audience for the Institute for Health Policy Studies, the Grand Rounds audience here, is pursuing the goal of policy relevant evidence. How do we actually do research that is going to have policy impact? Another theme is making evidence-based policy decisions. So with my hat on from the California state role, how did I try to use evidence in order to actually inform the policy decision? So helping people think about the work that you do and how a policymaker might use it. And then the last theme is reflecting on the lessons learned from these public health leadership jobs and including the cross-agency leadership in creating, sharing, and supporting the implementation of the K-12 schools guidance. So first of all, the impetus for this work was both personal and professional. So the overall goal of everything that sort of happened for me and the work that I did in collaboration with others over the time of the pandemic was to directly inform school policy and school opening policies. It was personal because my son struggled on Zoom right in the beginning of the pandemic, pretty much stopped going to any school for spring and fall of 2020. He had undiagnosed ADHD that made it extremely hard for him to participate and had a lot of emotional dysregulation, depression, and anxiety because of it. So deeply personal, and then also very professional because my patients and families at Zuckerberg San Francisco General Hospital were, first of all, disproportionately devastated from the health effects as well as the deep inequities of access to education. So in like literally the stories that in the middle of April 2020, I woke up one weekend and I was like, we have to do something about schools. And so I said, I have all these research skills and health services research and implementation science. How can we use research to help get schools back open? That was kind of the driving force of much of what happened. So my original hypothesis in April of 2020 was that everyone was already infected. All we need to do is measure everybody's antibodies for kids and the teachers and get everybody with antibodies back into the classroom. So I started having some conversations with George Rutherford, who many of you guys know from here at UCSF, and also the San Francisco Department of Public Health partners, to see if we could start testing in the city-run learning hubs. How are we going to find those kids who have those antibodies and those teachers that have antibodies? So that I thought was great. And then we found out some more information later in April of 2020. Unidas and Salud does their testing in the mission, where very few children were found to be infected either with PCR or with antibodies. There were data coming out of Iceland showing the same thing, and then Spain. So part of the story here is that in doing this kind of research in COVID in particular, there's a lot of pivoting that has to happen. But the continued relationship with public health policy makers and multiple different stakeholder groups is actually part of what drives this kind of research. So then in summer of 2020, there's mounting evidence that schools could be safe, and we knew that school closures were harmful. We saw international experiences of how to do it right and how to do it wrong in terms of safety. And then we also saw that there was a limited illness burden in children, but that families with children were bearing a large brunt of the economic devastation, which is mediated through school closures. There were starkly deepening existing disparities already for low SES students, increasing anxiety and depression, and then signs of increased child abuse, domestic and intimate partner violence. So the twin goals all of a sudden were to both do safe schools. We knew some implementation lessons already from those international experiences, but also successful schools. How are we going to get schools open and children actually in seats? Because the important policy point here is when you're looking at metrics, we are looking only at COVID cases. We need to think about the other also important metrics that we weren't necessarily following, but the success metric of getting schools open and getting kids back into seats were really important. We couldn't just focus only on direct health effects. We had to think about those indirect health effects. So the implications from some of those international studies, we did have several safe practices. By the summer of 2020, we knew masking, physical distancing, stay home when sick, and doing symptom screening, ventilation, symptomatic and asymptomatic testing, and then small stable cohorts. All were layers that we knew could have some role in keeping things safe in the school environment. For me, the very specific questions were, what about the things that were major barriers to our success goal? And those things, so asking about the importance of each of these layers, specifically looking at physical distancing and small and stable cohorts, I had a hypothesis that it's possible, as did the American Academy of Pediatrics at the time, it's possible that physical distancing at the time was the recommendation in the US was 6 feet, but the AAP and internationally was saying 3 feet. We were thinking maybe that's actually doable. And then also small stable cohorts. How much do we actually need to keep those small, really small class sizes? So as I was thinking about research, how are we going to use research? The antibody hypothesis, no, I no longer can pursue that. So how are we going to think about doing this other research? How do we create policy relevant evidence that was actually going to try and move the needle for schools? First of all, obviously defining a policy relevant question, which is what that slide that I just showed you was about. Which are those layers that we knew were really going to be changing the success of schools? That was the driving policy question. Can we change some of those policies in order to improve health outcomes, long-term health outcomes for educational reasons for kids? Another key step in doing this policy relevant research is involving those stakeholders in refining the question, designing the study, thinking about the potential changes in policy that might result even in the design phase, right? So we can begin to think, what is the highest impact information we could generate that actually might move the needle to make it the most policy relevant information we can provide. Another key step, as all of you guys know, is timeliness, and it's sort of the big bugaboo in doing policy impact research, is because research takes a while and policy has to move fast sometimes. And then the last part is the sharing of the results, interpreting them in context, and then sharing those policy and implementation implications from your research, which is defined as the last mile problem. And I'm giving a shout out to my father, who's a professor of health policy, of public policy at Cal. He's professor emeritus. for describing this as the last mile, the implementation problem, along with also Preston and Wildofsky also have a book talking about the last mile problem. And I think the most interesting part about this is that we need to think ahead to step 4 while we are still in step 1 and step 2, because if we don't think about the implementation issues during our design phase, then it actually is not going to be as impactful research. So where did this lead me to? A research design that was trying to ask the question of what policies can we potentially peel back? This is a stepped wedge design is what I was proposing at the time in the summer of 2020, adapted from an article that came out in JAMA actually earlier in the summer, basically looking to say we would take school clusters, so recruiting a bunch of different schools in the area, randomize them all, so at least 10 clusters of schools, and then week by week, have people do weekly testing. And then in that first chunk, you see that white chunk of time, week by week, school opening policies. All 10 clusters start with their school opening policies. And then as the weeks go by, you begin to roll in a peel back. Step 1 is peeling back at least one safety layer that maybe we think is not as evidence-based and is blocking the successful part. And you can see that in the green phase, everybody rolls it out week by week. Each cluster rolls it out in an ordered way. And then you re-randomize at week 15, and there's a new ordering of how people roll out their step 2 policies, which is peeling back another layer. So this is the same design, but just showing you where the analysis shows up, and then where the analysis and re-randomization and where the final analysis is. And then highlighting weekly PCR testing that we were going to be doing in collaboration with the Joe DeRisi lab. So in order to get this study rolling, the really key question is, what are those opening policies? And then what's stage 1 policy going to look like? And what's stage 2 policy going to look like? And the way we were framing it is, what are the pain points for what is the hardest thing for schools to do that are going to be blocking kids coming into school, creating the greatest blockages? And then what's feasible for them to roll out in that week by week? They have to make these changes, and what's logistically feasible? What is emotionally feasible because people have risk, issues around risk tolerance? And then what is the public health risk tolerance? So what does the San Francisco Department of Public Health say? Okay, we would feel comfortable with you rolling back this one layer, right? So I ended up spending tons of time having extraordinarily interesting conversations with a lot of different people, San Francisco Department of Public Health, school administrators, teachers, families, and key scientific collaborators way beyond what I normally do and what I think what all of us normally do. There's the pandemic really enabled and encouraged a lot of cross-disciplinary collaboration that we don't normally do with virology, infectious disease, implementation science, primary care, pediatrics, preventive medicine. All of us had to get together and have conversations. So I'm not going to read through all these names, but I do think it's really important to just kind of give the shout out and to remind people the incredible work that we all did together and we continue to do together to try and actually figure out the answers to these really important public health and societal questions and policy impact, policy relevant research. Working with virology and testing, like these are, basic science and infectious disease partnerships, pediatrics and preventive medicine, the San Francisco Department of Public Health partners, and these are all people who spent time thinking about these problems and thinking about this research in particular. School administrators, the teachers. I ended up talking to the California Teachers Union, the San Francisco UESF Teachers Union, individual teachers, with a special shout out to Emily Frank, who is both a pediatrician and a teacher in the Oakland Unified School District, and then talking to a lot of families through different organizations, Decrease the Distance, which is one of the founding sort of family-oriented groups, and then also, of course, the CARES webinar, which is the UCSF founded and led by Liz Rogers and Lee Atkins McAvoy group focused on how to support schools as they do reopening during the pandemic. And then finally, funding, of course, as we think about how do we do our research, how are we going to fund it? So Department of Pediatrics Development Office, because this research was so short term, it had to happen so fast. We ended up using more development dollars, the Chancellor's COVID Fund, which was very helpful, and then a couple outside funders, foundations also supporting the research that ended up being done. So the study that I was talking to all those people about and all that collaboration was really around that stepped wedge design. And unfortunately, the summer surge then that happened in 2020 ended up really decreasing everybody's confidence in the idea even of school reopening. And that you can see that's that surge that I pointed to with the blue arrow, which then ended up meaning that the step wedge design kind of went down the drain because people were not feeling at all like they could peel back any layers. There was a question even, are we going to reopen it all? Never mind what layers are going to be in place. So it was an important lesson in pulling together a bunch of people, but then also needing to be flexible because sometimes things change rapidly during the pandemic. So we ended up building on the momentum that we had and doing a study in the San Francisco summer camps over that summertime, basically doing an indoor camp pilot to test the feasibility and acceptability of student self-collection of testing in K through 8th graders. And that was actually, again, we knew that there's probably going to be testing. It's one of those big layers, and we knew it's probably going to be important. How are we going to do that feasibly? We also ended up observing the camps in action, watching the successful masking, stable cohorts, physical distancing, hand hygiene, ventilation, the whole 9 yards, documenting, yes, they can do it in these indoor camp settings. And there were no documented cases using that testing that we did by PCR at the beginning or the end of camp in the campers, the camp staff, or up to 2 household contacts. So the implications from that is that it's possible to follow those public health principles and that the student self-collected PCR tests were highly feasible and acceptable for students even as young as kindergarten. So this is an implementation study, right? If we think about the types of studies that we can do to inform that are policy relevant, it actually ended up the findings here actually ended up informing testing advice for the rest of the pandemic. I talked to Massachusetts about it. They ended up using this method of allowing students to self-collect. Chicago public school system, and of course, when I went to the state job and all the testing that we're doing in the state is actually for schools is self-collected. We knew that students would be able to self-swab effectively. And the really important take-home point, people are like, well, but self-swabbing, maybe it's lower sensitivity, et cetera. But the acceptability of this test was so important. There were kids who had gotten that really terrible nasopharyngeal way in the back, the brain picker test, and the kids and families alike were like, oh, I don't want to do that, and we would say, no, it's the front of the nose, and they were like, oh, okay, no problem. So if you have a slightly lower sensitivity, but you actually get the test done, I kept on explaining to people, and I think it's an important framing, if there is no test because somebody refuses to do it, you have 0 sensitivity with that test. So we know that testing had to be something that was probably going to be again and again in a school setting. We needed to have something that was acceptable for students. Another study that I ended up doing during that time or participating in also, with an eye towards how are we going to impact things. How are we going to learn without having a step wedge design? How can we still learn what to do for schools? What's the safe approach in schools? We use modeling techniques. So that it was in partnership with some really fantastic people at UC Berkeley, Jennifer Head and Justin Ramais. The take-home points here is that masks and stable cohorts alone are associated with decrease in infections, even more so than actually weekly testing of teachers and students. And this was in a time when we did not have great access to tests. This is a finding that they were doing their work in the summer of 2020 into the fall. And so this is extremely helpful information to give confidence in how can we do school safely without necessarily having that testing layer. And of course, it was prior to vaccines. So these were sort of the only interventions we had at the time. And my contribution here was actually helping them to think through that the separation by high school, middle school, and elementary school. Most of the data we had at that time was actually always lumped together, the high schoolers and middle schoolers. So it was great that they knew to separate those out so we could actually begin to understand different types of school settings. And then the other study that we ended up doing, because we couldn't do step wedge, which is sort of like the strongest study design we could come up with, the next best option was to do this observational design, which is it was a study led by Cindy Kaiser, and like we collaborated together. Cindy Kaiser is in the Department of Pediatrics in the Division of Hospital Medicine. And we used the observational design because we knew there would probably be variation in practice across the different learning settings. This was in the fall, or the November to February of 2021, looking at the learning hubs in San Francisco. So these were those small learning hubs for kids in public schools that basically were just a place for them to get Wi-Fi access and adult supervision during the day. They had small stable cohorts. And what we did was a mixed methods approach where we observed practices as all site visits, observing practices and gathering qualitative data on the bearers and facilitators to participating in those layers, to actually being able to sort of adhere to the recommendations. And what we found in those observations was that there was variation in practice, not shocking. It tended to be that the adults were better than the students at adhering to those things, particularly around masking. The students did an okay job, but not great, and the adults did a much better job. I think it was like 75% or so, and the adults did around 99% consistent with masking. And then stable groups and cohorting was a little bit challenging, but they generally did a good job. The challenges were outdoor time was sometimes hard, and siblings was sometimes not being able to interact with their siblings was hard. There were 36 cases in the hubs at the time, but only one documented transmission, which is adult to adult transmission. So our ability to learn from the variation in practice was very limited because we actually couldn't figure out, we didn't have any transmissions to actually try and differentiate between practices and seeing what was more effective versus not. But we did, the implications from the study is that the implementing those layers was feasible even at higher risk settings. People at the time were saying, oh, younger kids are never going to be able to comply. And, people from lower SES communities might be harder. They're going to be less, it'll be more chaotic. And what we found is no, with the right structures in place and the right supports, they absolutely could do it. And there was, and it was associated with no student transmission, even though there were 36 cases in the hubs, there wasn't any student transmission or student to adult transmission. So it was an important demonstration that at least if we had all those layers, that could actually be a safe environment. And then the last study was a clinical epidemiology study, and this one is not yet published. All the rest of them have been published. And this was focused very much on how to make schools more successful in a very specific kind of way, which was about keeping students in school, measured by days in school, or what I like to say is butts in seats. And the framing for this is that we were looking at the utility of illness symptoms for predicting COVID-19 infections in children. We know that COVID-19 symptoms are super nonspecific: cough, runny nose, fever, abdominal pain, headache, fatigue. They overlap substantially with other childhood viruses. The question was, can we inform national and state recommendations for symptom screening to limit missed school days for testing? And so in order to try and answer that question, we reviewed the symptom screening results and test results from multiple different practices around the Bay Area from April of 2020 to November of, that's 2020 in this type, for children 0 to 4 and 5 to 18 years. And what we found was that the highest positive likelihood ratio, meaning the strongest association basically with having a positive test after you've been screened, was if you got screened positive for having a prior exposure to somebody with COVID-19, or if you had loss of taste or smell. So those are two things that are very specific for potentially going on to having COVID-19 in the child population. What we also found, not surprisingly, that nasal congestion or rhinorrhea and sore throat were very, very common symptoms that had a likelihood ratio of about 1, meaning that there's no change to your chance of testing positive if you have one of those symptoms. We also found that there are very high numbers of missed school days associated with exclusion and testing to find one case of COVID-19. So you can take your, you can estimate the number of missed school days based on the fact that you would have to stay out to get tested, and how many kids actually would have had to stay out for any one of these symptoms. You can estimate how many missed school days there would be. And so the implications were that exclusion and testing for common non-specific symptoms may lead to excessive missed school days. There's one really important limitation, is that was all based on the original strain and potentially some alpha variant. The set of symptoms now with Delta and with Omicron are very similar, like those symptoms are similar, but the distribution might be different and the numbers of patients who are symptomatic are different with them. So it's important, as we now are moving into this endemic stage, it will be helpful to have a system to keep on updating these analyses, mostly with the eye towards, let's make sure we're not doing more than we need to in terms of symptom screening and keeping kids out of school and excluding them for testing. And even now, there's a couple options to consider now based on those findings. One would be allowing for rapid tests to clear symptomatic students if they have non-specific symptoms. So the rapid tests are, they tend to be a little bit less sensitive than the PCR tests, but they come back within 15 minutes. And we know that if you have non-specific symptoms, the chances of you actually having COVID-19 are very low. So let's allow, if people don't feel comfortable not testing at all, let's at least use rapid tests instead of PCR. And then some schools or some policymakers might consider not excluding for those very common non-specific symptoms that don't change your likelihood ratio or don't change your chances of having COVID, even if you have them. So I'm going to switch over now to the next theme or the next phase of the talk, which is talking a little bit more. So I just talked about how do we do policy relevant research. Now, what are the public health leadership stories and lessons learned in using evidence to inform policy? So how do we make evidence-based policy decisions? How do we basically put what we know into practice if you're a policymaker and it's somebody thinking about the implementation side of it? And this, again, calling out that last mile problem. So we have the evidence, but then how are we going to do the implementation? Because the implementation is pretty complex. First step, sharing and interpreting the science and thought leadership. It's what academics actually do very effectively. It's a lot of what I did before I took on my public health leadership roles. I did medicine grand rounds in July of 2020, leading that CARES UCSF webinars and the listserv, and trying to really provide a lot of information and interpret the evidence for schools and families. Media collaborations. I got solicited by the New York Times to write an op-ed based on the medicine grand rounds, and then I got approached by the Chicago Public Schools testing. A group trying to figure out how to do testing in Chicago Public Schools. So sharing and interpreting the leadership, the science is, that's a big part of what we do in academics. And then the last part is service. So sometimes academics get tapped to go and do the kind of service that I did both for the city of San Francisco and then for the state of California. And you can do it in a big job or a small, like in a big way or in a small way. But that's another component that I think is an important piece of what we do. And I ended up being deployed to the San Francisco Department of Public Health out of my Zuckerberg San Francisco General Pediatric job to support the design of their school testing strategies for schools, or sort of inform how they actually were going to give recommendations and sort of support school testing. And then in December of 2020, I got deployed to the California Department of Public Health and Health and Human Services under Mark Galley, who's the health secretary there, to lead the multi-agency safe schools team. So that was a cross-agency education, public health, the OSFOD group, which is actually, they worked on health and hygiene, and the Office of the State Architect working on ventilation. So really pulling together a lot of different players to try and support schools who are struggling to try and figure out how to open safely. So I'm going to pull the timeline apart a little tiny bit. I'm going to talk you guys through this and highlight the sort of the lessons learned from the experience. And so I'm just going to remind you briefly of the timeline of schools and thinking about schools. First, to remind you, we kind of shut down. Sorry. we shut down because we thought that schools would drive transmission and that kids would get COVID. Then we thought maybe it'll be safe to reopen. We looked at other countries and we understood how to do schools safely and the importance of in-person instruction. That's what we talked about, what I mentioned already. And then there was that winter surge in 2020 to moving into 2021. And then we slowly started to open with vaccines. And on the other side of the surge, there was an emphasis on in-person instruction. And then as we prepared to try and really be full, there were some schools reopening throughout California in March, April of 2021, and then really preparing for that reopening in the fall, and then having Delta come and sort of gritting our teeth to get through the Delta surge. So I'm going to, like I said, I'm going to pull it apart to sort of talk a little bit about actually the themes of how government works, all the different arms of government actually sort of interplayed in a way that in reflecting on things, it really helps to explain how schools happen the way they did in California and to better sort of understand the role that public health plays and how we can sort of enter into the conversation and understand a little bit better. So first of all, there was in March of 2020, the executive branch, so Governor Newsom declared a state of emergency. That was early in the beginning of the pandemic. On March 7th, there was a student who tested positive for COVID-19 in the state's 5th largest school district, and that started school shutdowns. And after that, it was pretty fast throughout the rest of California. Throughout the next couple weeks in March, everything shut down. Schools pivoted as fast as they could to distance learning and supporting families, but it was pretty extreme sort of shutdown. In June of 2021, there was a bill that was passed. So this is a partnership between the legislative branch and the executive branch, so the governor and the legislative bodies sort of work together to pass SB 98, that was June 29th. It allocated an additional $5.3 billion for schools to respond to COVID-19, including reopening safeguards and distance learning. It also set requirements for distance learning, mental health, student re-engagement, and in-person instruction. And it implemented what's called a hold harmless clause, meaning that if you didn't do in-person instruction, you would still get paid. So we'll talk a little bit more about that in a couple minutes, how that plays out for the rest of the year, because that SB 98 was in effect until June of 2021. So this year it was 4 years. Then, as I mentioned, partway through the summer, basically, we had a big surge. And in fall of 2020, there was a lot of consternation, a lot of difficulty. There was a lot of this roller coaster of, what are our COVID rates? Are we in orange? Are we in red? Are we purple? How are we going to open next week? Are we going to be able to open a week from now, or 2 weeks from then? Are we even going to open at all? And then the union negotiations during that time to reopen, the teachers unions, the nurses, the school nurses, the school staff negotiations were very difficult, like very contentious, because of the lack of clarity about exactly how to do schools safely. And then also that hold harmless legislation meant that there was no real impetus or that there was a lot of barriers for actually being able to reopen. There was no like big incentive to reopen. So there's a lot of emphasis on doing distance learning still until people felt more like they actually felt they knew how to do it safely. That was true in urban counties. The interesting thing to call out, most rural counties in California actually stayed open and opened in person in August and September of 2020. And then a lot of private schools figured out how they marshaled their resources. They weren't subject to the hold harmless, and so many of them opened for in-person learning. And it's mostly the public school districts across the state that really stayed closed for almost all of fall of 2020. And San Bernardino School District then announced in November 17th, right at the beginning of the winter surge, that they weren't going to reopen for the entire rest of the school year. And there was a lot of concern in the governor's office and at the state level that meant that would be the beginning of many schools saying that. And so there's a real focus on we have to do something to make sure that the momentum does not go in that direction, and that schools do get reopened, or at least have more in-person instruction in order to support those kids. So then the January guidance came out. So the California Department of Public Health guidance, schools guidance, they had put something out in August, and then we reorganized it in January. I was brought on in December of 2020 and helped the team to rewrite that January guidance in order to encourage more reopening, have more clarity. The August guidance, there was a lot of concern from school administrators and families and teachers that there wasn't enough clarity. So the January guidance was to give more clarity to everybody about how to open safely. What does it mean to open safely? And here's the pathway forward. There wasn't as much vagueness. It was a little bit more concrete for folks. And just call out, that's a public health order, so that's an executive branch order. So that's something, because of the state of emergency, it holds the force of law, but it's done through the executive branch. Then in February 19th, teacher vaccinations were prioritized. So the governor accelerated vaccines for the K-12 school staff, leading to almost everybody receiving access by early March. Again, that's an executive branch move. And then on March 5th, the legislative branch and the governor came together to get AB 86 passed, which allocated an additional $6.6 billion to accelerate the opening, expanding mental health and academic supports. And the change here was that it incentivized, so they did a financial incentive for people who opened by a certain deadline. And actually, I forget what the deadline, I think it was either late March or early April, to have schools be open by then, in order to really try and align incentives so that there's, because until then there wasn't a real incentive to do the opening. So the idea was to really help encourage, through positive alignment of incentives, the reopening. And you'll notice that some people were talking about there should be a mandate for full reopening. That would have been a negative consequence. And the move here was to do a positive, sort of a positive incentive rather than a negative consequence. And then to get to the fast forward through the spring, where there were actually a lot of schools that reopened in California because of that incentive system. SB 98 in June sundowned, and so that hold harmless clause was no longer in effect. There was, they passed it in their budget resolution in the summertime. They did pass a description of what it would mean to do remote instruction. They would allow people to get paid, schools to get paid for remote instruction, but it was very much smaller, like a much more limited access to what could be done to really encourage people doing the in-person instruction. And then in July of the summertime, the CDC and CDH guidance came out. And so how did we try and set ourselves up? Now the question is, okay, we're going to reset, right? So in the summertime, how are we going to set ourselves up for success using everything we learned from the prior year with our evidence-based policy-making approach? So the learnings were a lot based on all of what we knew about physical distancing, that we could do less physical distancing. We stick with the mask. We should allow for modified quarantine, which means a different way of doing the quarantine, which I'll describe in a bit. But also we knew enough about Delta when we were releasing our guidance that we knew we needed to actually still have some good safety layers in place, because we knew it was a more transmissible virus and that it could actually still cause some outbreaks. And I'll show you the study that informed that in a minute. So just to remind you guys, this is the conceptual model of spread from schools, and it's what informed our 2021 to 22 guidance. Step one, you have, in order for there to be COVID spread, you have to have virus in the community. Step two, you have to have virus walk onto the school campus. Step three, there has to be in-school transmission. It goes from one person to the other. And step four, then it goes back out to the community. Whoever got it in the school then passes it on. So most of the focus through most of 2020 to 21, so all that fall and winter, and as we're reopening in March of 2021, the focus was on in-school transmission. Let's get our physical distancing, stable cohorts, masking, hand washing, make sure we walk only in one direction in the hallways, and some emphasis on ventilation, but it was all really focused on step 3, trying to prevent that. We knew that vaccine and testing could help us shift our perspective to steps 1, 2, and 4. So sorry, I'll say that again. Step 1 is virus transmission. Vaccines are going to decrease that. Vaccines are going to decrease the risk of out-of-school transmission. And testing is going to help us with decreasing the risk of virus coming into the school if we do asymptomatic testing. So these layers is the famous Swift model, which I think probably most of you are familiar with. But all people 12 plus in school are vaccinated, now 5 plus actually. So just that's for the news. You can update this slide. And then testing and if you're sick, you should stay home. Masking indoors and hand hygiene, improving indoor air quality and outdoors when possible. Notice that on this slide, there is no physical distancing and no stable cohorts because they were the biggest barriers to successful in-person learning. And if you remember, that was what I was trying to ask way up at the top of this talk in our step web design. Could we take away those layers that were the biggest barriers to in-person instruction? And there's some good data that came out in March out of North Carolina and Massachusetts, actually saying that physical distancing, certainly 6 feet, is not necessary. And in our California guidance this year, actually, we gave no minimum physical distance requirement because the burden of proof was on physical distancing to prove itself that it actually made a difference. And there was not great evidence that was actually making any difference to decreasing the risk of transmission in schools. There were all those other layers that were going to be much more important. And the same thing, stable cohorts, there's data that shows it, but it's so hard for people to implement that we needed to rely on those other layers that you see on the screen. I think it's helpful, and I'll come back to this just briefly at the end, which is to say, with Omicron now on the horizon, I think this conceptual framework actually still is important. We have a huge testing program in the state of California. We're blessed with having it. There's a ton of money that's been put into it, a ton of infrastructure. So even in the face of Omicron, I actually think that our testing and our masking, all of those things are still quite important and means that we don't have to actually move into thinking about doing remote instruction again. Just briefly, this is one key piece of data that I'm not officially co-author on, but we talked a lot about it actually in the state job that informed our decision making for the guidance, for the California guidance that came out in the summertime of the school year of 2021-2022. It was a school outbreak that happened in May of 2020, which is early Delta days. Second grade classroom, the teacher was unvaccinated and came to school symptomatic for 2 to 3 days, thinking that it was allergies. Unfortunately, read out loud without a mask in the classroom. And there were a lot of infections that came from it. You can see all of these positives, the full front row, 3 in the second row, 1 here, and even to the back of the classroom that got infected. All of them were Delta infections, and this is the first school outbreak with Delta that we knew about and learned a lot from. And then here's the picture of the spread. Here's the index case, the teacher, and then these are all the dark blue is all the kids in the classroom, and then there's some siblings who got infected. And there was a separate cluster actually that was associated with a sleepover that could not be traced back to the teacher, so it's unclear exactly how that happened. But the take-home points basically are, first of all, the spread can happen outside of school as well, as we saw in the 5th grade sleepover. Vaccination in the broader community was extraordinarily high in Marin at the time, and probably was helpful in the outbreak not spreading any further than just these 2 clusters. And then, of course, the key layers: vaccination, masking, stay home when sick. And it informed our mask policy a lot. We showed this data before it was published to the local health jurisdictions in all 58 counties and also the governor's office, literally like 2 days before the CDC came out with their school's guidance, but then guided ours. And it made us decide to be more conservative on masks than the CDC, which we were not anticipating, but this data was quite compelling. And then the CDC actually ended up following suit to get aligned with our guidance when they also had their Delta data come in a couple weeks later. So just a couple lessons learned also from the implementation pieces around the great diversity of California's 50th counties. So it was an extraordinary pleasure actually partnering with the local public health officers throughout the state, extraordinarily interesting, extraordinarily dedicated leaders across a diversity of different populations. And you can see on one side, there's, variation right now in COVID case rates. Some of them sort of echo some of the Newsom recall results in terms of political landscape. It meant that I got a lot of incoming speech from the political parties, people who are anti-Newsom, anti-public health. It meant for me, working with this diversity was actually extraordinarily interesting. I needed to grow a layer of Teflon, because there's a lot of negative energy coming through, but also a deep appreciation for everybody trying to work in a tough situation, regardless of what's happening. Personally, for me, getting attacked, like I understand it's like, you're a figurehead, usually as a public health person, so you can't take it personally. And people are dealing with, people are scared, they're confused, they're angry, they're trying their best, they're, feeling vulnerable, and so trying to help support those folks. And the message I continue to use both personally and also in presentations and discussions with people is, if you want to go quickly, go alone. If you want to go far, go together, right? Unprecedented levels of collaboration are needed here. And so we, particularly when the mask mandate came out for us in California, there's a lot of pushback there. And so this is where the title of this talk comes from, which is, if we don't enforce, COVID enforces. People are like, what if we don't enforce the mask mandate? A lot of school administrators, what if we don't enforce, or county superintendents, what happens if we don't enforce? Is the state going to come after us? And the answer is, we are in this together. We are at the end of the viral invasion. Like, the analogy I use is, we're at the end of the movie, the movie of the viral invasion coming in, and we all got to come together. And Delta, and now unfortunately Omicron, like the virus is pulling out the big guns, and we have vaccines, and we need to get ahead of the virus by using our vaccines. And if we don't enforce, COVID is going to enforce, meaning that there will be infections in schools, and it's not like you have an option of not enforcing your mask mandate because nothing bad will happen. If you don't enforce your mask mandate, COVID will enforce your mask mandate. So helping people sort of begin to understand that and encouraging them to please come together. So that helped a little bit. Unfortunately, what ended up happening, and I'll talk about this in a minute, is those schools ended up getting those schools where they didn't enforce it. It did end up being that they ended up shutting down at the beginning part of their school year, which I'll explain a little bit in the next slide. But I want to come back to this sort of the contentiousness piece of it and actually frame it as, so there were two lawsuits. There's the role of the judicial branch. So we talked thus far about executive branch, legislative branch, but what is the role of the judiciary, and how does it interplay with the executive branch and public health? I ended up I have a dubious distinction of being named in two lawsuits with Governor Gavin Newsom, as well as along with Mark Alley and Tomas Arzon, who's the director of public health for California. There's a lot of loud voices that happened in this pandemic, a lot of anger, as I already mentioned, saying this is too restrictive. You have to reopen schools. So the first lawsuit was around distancing, saying that physical distancing should not be used, and then that high schools should be allowed to have looser restrictions that were than what were available, than what were given in the January guidance. And it generally happens, these two lawsuits, and the other lawsuit was the masking lawsuit, it's when people feel like the executive branch and the legislative branch aren't sort of doing what they want them to do, and so they turn towards the judiciary to try and to affect change. It's an interesting dynamic to sort of see that's how people use it. The problem with suing the state is that if somebody wins, then that weakens the state in a relatively permanent way if you do it through the judicial branch, to be able to do good public health interventions in the future. So it's just helpful for you guys to sort of think about what that interplay looks like. I was personally surprised when I started to get sued in the beginning because I was like, I'm all about opening schools. Why are you suing me? My husband was totally not surprised at all. He's like, of course you got sued. What took them so long? And then the other thing, as a public health leader, I got totally vilified on Twitter, like dragged through the mud in a way that was apparently super ugly. I decided not to look at Twitter at all because I knew it was going to be devastating and it's going to have a really hard time getting my work done. I ended up being okay with being sued because it actually ended up moving things along in our guidance in a way that was sort of helpful. The CDC made a change in their physical distancing, and then we were able to make the change in the physical distancing relatively easily, in part because the lawsuit was creating some momentum in that way. But I was surprised. On the other hand, I was not at all surprised by getting sued for masks. I was totally willing to take the hit because I knew about that Marin study. And because I knew that doing that mask on mask, doing that, the masking was going to allow us to do what's called a modified quarantine, which allows for if the exposure was in a situation where both people were masked, there's a COVID positive person and a COVID negative person. The negative person was wearing a mask, the COVID positive person was wearing a mask. That allows for in schools what's called a modified quarantine. You can stay in school for in-person instruction as long as you're doing testing. And so I knew that that was actually going to really keep butts in seats. As I said, like keeping those students in the classroom is super important. We took a lot of heat for it. We did end up getting sued. But like I said, I was really fine with it. And the only, mixed story for me is that Delta ended up proving us right, unfortunately. I honestly would have been really happy if we didn't have Delta. And I would have been happy to be proven to be overly conservative and we could have peeled off the mask mandate. So there's, that again is sort of part of the public health leadership is being able to say, I understand what's going on. I'm going to stick to my guns. And unfortunately, then Delta proved us right. But I don't take any personal pleasure in that particular piece. The last theme is listening for, eliciting, and lifting up voices. So we get a lot of incoming from people who did not like the restrictions. The people who did appreciate the restrictions didn't actually say as much because those restrictions were in place. It's very helpful for public health leaders and politicians actually to get emails about things that are important because we get a lot of incoming from very noisy, other parts of the state, and particularly for the pediatricians, for the academics, for the infectious disease folks, if you feel like there's data that you think is being implemented correctly, or if you don't think so, and you're like, oh, it won't really make a difference. It does make a difference. Please send me emails. Send me nasty emails because the nastier they are, the more impetus that it will, move things along in a way that's actually very meaningful. So don't be worried about making noise. And then the other piece for me when I was thinking about equity is that it was very important to listen to the often silent voices, disenfranchised, and to reach out to them. Otherwise, those loud voices were going to dominate. So a lot of the urban families there was a lot of very anxious urban families, particularly families of color, people who had already been disproportionately impacted who didn't feel confident going back to school. And so making sure that we were listening to those voices, eliciting them, because they were not writing us emails about how important it was to get back to school. But it was really important to help build their confidence so that they felt like it was safe to go back to school in the fall. So there's this interplay, just to summarize the lessons learned, there's an interplay between the legislative branch, executive branch, and judicial. Thinking about what is the compared to what, we got to think about both safe, so lower that COVID infections, but also successful keeping those kids in in-person instruction. The only way we're going to get through this is unprecedented levels of collaboration, the diversity of California, but that important partnership, remembering that COVID is the enemy instead of fighting between each other. And then when we're fighting inequity, we have to remember every step of the way whose voices are getting heard, listen into the silence and lift up those voices, elicit them. So I'm going to pause because I've already run out of time for questions. We can make these slides available if you would like after the talk. Does that sound good, John? I'll do it that way.
That sounds great. I know I'd love to hear more about, but we do have a question and I encourage people to add other questions to the Q&A box. Janet Kaufman, one of our IHPS colleagues, asked, what do you think were, I mean, you've articulated a lot of the things that you think made the process successful. Are there other components that maybe you didn't mention that you think were keys to being successful in working with the state government officials in this role? And then things you wish you might have done differently that you're willing to reveal publicly?
I think there's a lot of listening. Listening to understand what are the implementation issues, right? Because if you're at state government, it's easy to sort of think theoretically and not actually figure out what are the issues on the ground. You can come up with some great solutions, but then if you don't talk to the people about the implementation barriers and you sort of make guidance that, doesn't notice the implementation barriers, it's terrible for them and it's terrible for you. And the story that probably is the one that that was the hardest, we did a physical distancing decision in the January guidance to say there should be a minimum of 4 feet of physical distancing. In the August guidance, they had not had a minimum. They didn't say you have to have they sort of said 6 feet as practical. And I joined the job in December. The impression that was that across the state, everybody was doing 6 feet. And there was maybe 1 or 2 schools or districts that were doing less than 6 feet. It turns out once we made that guidance, all these people came out of the woodwork and they were like, we've been doing 3 feet and now you're making us go to 4 feet. And this is a massive problem for us. And you're going to send a ton of kids back home because we can't fit them into the classrooms. And I was like, oh my God, I came into this job to get kids back in school. And here I wrote this guidance that I didn't know about. So part of it is it's on them because they were doing something that kind of didn't go along with the spirit of the guidance, but it's also on us to not have double checked, before we did it. Now, if you remember the time period is crazy, the intensity of you had to, when I came to the job, they were already saying we needed the guidance, a month ago. So it meant that we were under a ton of time pressure, but if I could do it again, I would have said 3 feet and not 4 feet. And we did 3 feet, we did 4 feet because we for a variety of different reasons. But if I could do it again, I would have not done 4 feet.
Yeah, it's, I have a question. I'll take the last one unless somebody types something in. But it seems that one of the factors that may have been particularly helpful in generating the kind of science that you were able to rely on was the existence of a private school network, or not even necessarily network of private schools, just the existence of private schools that independently or maybe with informal conversations with each other had already gone off and done their own thing. And that those schools, through their experimentation, to the extent that they tracked information and were willing to share it, helped to create an evidence base. And I'm kind of curious what your reflections are on that. Of course, we also learned from international evidence from other countries that were jumping into this ahead of us, but that existence of that private network seemed not only to generate some data that was local, that maybe was more persuasive because it was local data, but also perhaps also put some pressure on the local public schools to be more open to the idea of rapidly moving and listening to what could be learned from their neighbors. Mm-hmm. But that was just kind of the layperson perception. What's your sense of that?
Yeah, so the data that we used was almost never from private schools, quite honestly. The data that I generated was SUNY Kaiser was the learning hub. So that was actually run by the Department of Children, Youth and Families. That was facility for public school kids. The data that we used very specifically was not private schools because anytime anybody would bring up any private school evidence, the public school leadership and teachers would be like, yeah, but those are private schools. That is not relevant to our reality on the ground. So the data that really drove things for us was Massachusetts public schools and North Carolina public schools, where they, generated, and some Utah data actually. And that's, they were in a different place than California in terms of being able to have different school reopening policies. And so they generated a bunch of data that then helped inform us. But people even objected sometimes to the Marin study because they're like, well, that's Marin, blah, blah, blah. But, you know, that was an extreme of like how COVID spreads even in a slightly more, it was in a Catholic school, so even a slightly more controlled setting. So.
Yeah. Yeah. Well, I appreciate the North Carolina being a lesson. My daughter's boyfriend is a teacher there and was in the classroom all that year on a partial, you know, kind of half classroom type of approach in the first year. So interesting to hear that. We are a little bit past time. I really appreciate your presentation, both to learn more about the science that was going behind all of this, as well as some of the policy issues that you faced. And I appreciate your getting out there and not reading Twitter and recognizing that in the role that you were in, it was bound to be controversial, but you were making an effort to bring forward the voices that were not being noisy and also needed to be heard. So thank you so much for your service. And I'm glad that you are back at UCSF full time and back with us, although it was an easy sacrifice to do something good for the children of our state. So we were willing to let you go for a year for that. Thank you so much. And there is a secondary thank you for your incredible service that has appeared in the Q&A. This webinar has been recorded and will be on the website. And we can also share your slides up there for people to read about the 2021-22 academic year at their leisure. So thanks so much, Naomi, and have a wonderful rest of your day to you and to everybody who's been attending.
Thank you. Thanks, everyone. Thanks, Dan, for the invitation. Take care.